To help us understand the phenomenon above, let's create a fictional randomized control trial. So we have 1,000 people who are randomized to two groups, an intervention group and a control group. The two groups are followed up, let's say for 5 years, and perhaps there's a little loss to follow up, as we can see here. Evidence is about linking an exposure to an outcome. So the outcome here is, we said it's mortality. And in the intervention group, we can see that 5 people died, and in the control group, we can see that 10 people died. So that is called the experimental event rate and the control event rate, respectively. So critical appraisal, as we've mentioned before, involves 3 aspects. Firstly, what is the result? What is the effect size? Is it statistically significant? Does it matter? And secondly, the validity. Is this study biased? And largely we're looking at the methods of the study there. And the third step is applying that to the patient, applicability. So just on the first component of appraisal, what is the actual result here? Well, we're going to assume that the difference between the intervention and control group is statistically significant. So now we can go on to believe that the result is not due to chance. So how effective was the drug? And there are a few ways of articulating that. So a relative risk reduction is done by comparing the result of the intervention group compared to the control group. This formula looks a little complicated, but in essence it says relative to the control group of 2%, how effective was the drug? So 2 minus 1 over 2. So the relative risk is 50%, and that sounds very impressive. The absolute risk reduction is different. It takes a bigger picture. How effective is the drug overall? Well, that would be simply 2% minus 1%. So the drug reduces the risk of death by 1% over 5 years. It is the same drug, just a different way of articulating really the same thing, but it certainly appears more modest. As we can see here with numbers needed to treat, this is really an inversion of the absolute risk. It divides the number 1 by the decimalization of the absolute risk reduction, in this case 0.01. So this gives the number 100. So that means that 100 people would have to be treated with the drug, but only 1 person benefits. And that means that 99 people don't get any benefit and they could actually get side effects. So going back to the scenario I showed you above, the effectiveness of a therapy can be articulated in several different ways. Some, such as relative risk, can make the therapy appear more effective than maybe it actually is. And I think there's a big difference between relative and absolute risks, and it's probably more appropriate to use absolute risks when we share decisions with patients. The second part of critical appraisal looks at validity. Is the study biased? I'm looking at the methods. Was this a well-conducted study that I can believe? In this fictional randomized trial, we might look at the following. Firstly, we could look at table 1 in the results, and that looks at the baseline characteristics in the intervention and the control group. And if there was an issue or a bias in how randomization was done, the characteristics in the two groups might be different. The ages might be different, or the gender might be different. And that could infer that confounding could have crept into the randomized trial, and that's a bias. That would be called selection bias. A second type of bias to look for would be performance bias. That's when something else happens to the intervention group. Maybe they had an additional support from a nurse or something like that, and that could be the ingredient that underpinned the effectiveness of the drug rather than the drug itself. So you're looking at something called performance bias. If there's a significant amount of loss to follow-up in the intervention group, there could be some sort of harm from the intervention. That would be called attrition bias. If the variety of outcomes weren't blinded, that could be something called detection bias. And there can be multiple other sources of bias in randomized trials, such as reporting bias, selective outcome reporting, and also funding issues, which could raise issues with conflicts of interest. So now we've appraised whether or not the study is valid.
The third step in appraisal is applicability, and we want to assess whether or not you can apply this result to your patient. So where the trial patients, like your patient sitting in front of you, if you're a GP, was the treatment delivered in a primary care setting in the trial? If your patient has 10 medical conditions, is on 15 medications, but the patient's in the trial at only a single disease, maybe this trial is not generalizable to you and your patient. So you have to weigh this up, and that brings in the issue of uncertainty, which we all live with, particularly in general practice. You also have to think about the outcome. If the outcome is a score that doesn't particularly matter to the patient, or if the outcome is mortality or quality of life, it's quite obvious which is the more important outcome for that patient, and that's up to you to interrogate.